eminent faculty members and participants who have joined from various parts of India, and good morning to everyone who have joined abroad. Welcome to this live webinar. I am Sumit Kumar Madan from Zydus Life Sciences Limited, and on behalf of Zydus, I welcome our guest speaker, Dr. Naval Davar, all discussants and participants to this virtual symposium on judicious use of novel agents and role of MRD in AML. Before we commence the proceedings, I would like to welcome and introduce the host and the convener for this webinar under the aegis of Mumbai Hematology Group, Dr. Amit Khurana. Dr. Amit is a very passionate and dynamic hematologist and bone marrow transplant physician from Surat in Gujarat. I request Dr. Amit Khurana to navigate this program further. Sir, over to you.
Thank you, Mr. Sumit Madan. Very good evening to all of you. Today, our guest speaker for the day is Dr. Naval Davar from MD Anderson Cancer Center, Houston, Texas, USA. He's going to lecture us on judicious use of novel agents and role of MRD in AML. This webinar is brought to you by Mumbai Hematology Group, supported by Zydus, dedicated to life, and managed by Perfect Square. I thank Mr. Ashish Kumar, Mr. Sumit Madan, and Team Zydus, Mr. Yash, Mr. Kalpesh, and the Team Perfect Square, Executive Committee of Mumbai Hematology Group. Our guest speaker for the day, Dr. Naval Davar from MD Anderson Cancer Center, Houston, Texas, USA. All our discussants who are themselves eminent hematologists and medical oncologists, and you participants for sparing your Saturday evening. Tomorrow, that is 13th of August, Sunday, from 11:30 a.m. onwards, we have a webinar on management of sickle cell disease in 2023 by Dr. R.K. Jaina from SCB Medical College and Hospital, Cuttack. Now it's a time to introduce our discussants for the day, and we have a galaxy of them. We are displayed in alphabetical order. To start with, we have Dr. Abha Dubey from Arvita Super Specialty Clinic, Ahmedabad. Dr. Abdul Majid Kurwadangal from Government Medical College, Kozhikode. Dr. Bharat J. Parikh from HOC Vedanta, Ahmedabad. Dr. Bhavin Shah from HOCC Vedanta, Ahmedabad. Dr. Chirag Shah from Apollo Hospitals International, Ahmedabad. Dr. Girish Kamath from SDM Medical College and Hospital, Dharwad, Karnataka. Dr. Hita Diljit from Government Medical College, Kozhikode, Kerala. Dr. Jyoti Bajaj Soni from Gujarat Cancer and Research Institute, Ahmedabad. Dr. Komil Kumar H. Patel from Maringa Sims Hospital, Ahmedabad. Dr. Meenu Angi from Unipeth Specialty Laboratory, Ahmedabad. Dr. Nidhi Jain from Zydus Hospitals, Ahmedabad. Dr. P.P. Abdul Sahid from KIMS Cancer Center, Trivandrum. Dr. Rajan Yadav from Medical Oncology and Hematology Department, GCRI and BJMC, Ahmedabad. Dr. Rajni Priya Yedla from Mahatma Gandhi Cancer Hospital and Research Institute, Visakhapatnam. Dr. Sandeep Nimani from Sri Siddhi Vinayak Ganpati Cancer Hospital, Miraj. Dr. Sandeep Shah from Vedanta Institute Medical Sciences, Ahmedabad. Dr. Sanket Shah from HOC Vedanta, Ahmedabad. Dr. Shinto Francis Thekudan from Kozhikode, Kerala. Dr. Smita Kayal from Jipmar, Pondicherry. Dr. Rajasekhar Thirugnanam from Kovai Medical Center and Hospital, Coimbatore. Dr. T. Ramadevi from Gujarat Cancer Research Institute, Ahmedabad. And Dr. Vinod Gunasekaran from Kaveri Hospital, Trichy, Tamil Nadu. Now it's a time to introduce our guest speaker for the day, Dr. Naval Davar from Houston, Texas, USA. Dr. Naval Davar is Associate Professor and Director of the Leukemia Research Alliance Program in the Department of Leukemia at MD Anderson Cancer Center. He is a clinical investigator with a focus on molecular and immune therapies in AML and other myeloid diseases. He is a PI for over 25 ongoing institutional, national, and international clinical trials in this disease. These trials focus on developing a personalized therapy approach by targeting specific mutations or immune pathways expressed by patients with AML, evaluating novel combinations of targeted immune and cytotoxic agents, and identifying and overcoming mechanism of resistance. He has published over 260 peer-reviewed research articles. He is on the editorial board of numerous hematology journals. He is a co-director of the MD Anderson Cancer Center Heme Onc Fellowship Leukemia Rotation and he mentors numerous fellows and junior faculty. He is going to lecture us today on judicious use of novel agents and role of MRD in AML. Well, thank you so much. Over to you, Dr. Naval Davar.
Yeah, thank you very much to Dr. Khurana and the team. A pleasure to speak to you all today. It's a bright and warm Saturday morning here in Houston. Let me share my slides here, and we've all done this a few times before, so I hope to try and share some new information and then also go through some of the key points from the older discussions. And in the end, I will give a brief discussion on MRD. I think MRD is a very interesting and detailed topic, but unfortunately, there's not that much clinically today that we can do for MRD. I will kind of focus on the clinical uses of MRD and how we're using it in the clinical treatment setting today as it relates to both pre-transplant as well as post-induction consolidation settings. So these are my disclosures. So I think just to highlight, AML, disease of older age populations. Now, this may be different in different regions and countries. I know, for example, in India, AML is often seen in younger populations, also in Middle East. But predominantly, it still remains a disease, I would say, of an older population above 55, 60 years of age. And also we know that this impacts survival as patients get older age. They also tend to tolerate intensive chemo poorly, have more comorbidities, higher induction mortality, as well as a different biology of the disease with an enrichment of patients having adverse cytogenetics, high-risk molecular mutation features, and other such resistant factors. So it's a combination of decreased tolerability, increased comorbidities, as well as a different biology of disease that leads to a poor outcome in older AML, which is why a lot of the discussion we're going to have today will be about management changes, at least in the US, that have been heavily focused on improving this really unmet need of older AML population, where the survival has been below 10% for the last 4 decades. So I think one of the big changes that has come in AML, and I think again for residents and fellows, junior faculty, it is really critical to understand that AML is really not at all a homogeneous disease. In fact, in more and more time, I think over the next few years, we're going to even just stop calling it AML, because when somebody emails me or calls me and say, I have a patient with AML, it really gives me almost zero information. What I want to know is what subtype of AML they have by molecular and cytogenetics, because we all know that a TP53 mutated AML with 21% blast in a 70-year-old is a completely different disease than a core binding factor AML in a 34-year-old patient with a cure rate that could be 85% versus 15 to 20%. So I really think more than any malignancy, in fact, the molecular subclassification of AML really identifies very distinct disease, both in prognosis and importantly in treatment. And so I think it's critical whenever you're seeing an AML patient, discussing an AML patient, the first sentence really should be, what are the cytogenetic and molecular features of that patient at diagnosis, and then ideally even at the time of relapse, because not only is heterogeneous AML to begin with, but even at the time of relapse, we can see clonal shifts, clonal evolution with new molecular mutations emerging, as well as loss of old molecular mutations. This is also why it makes it very tricky to find one treatment that fits across the board for AML, and we're getting more and more into molecular or cytogenetic directed treatment options. So really critical to develop good NGS panels. I think that would be the first and most important thing for the next 5 to 10 years in improving outcomes for AML in every part of the world. So how do these genomics, whether it's cytogenetics or molecular, help stratify? So historically, we always did cytogenetics, and that did identify a group of APL, which did really, really well, 90-95% survival. Of course, early induction mortality has to be really well managed in big centers of expertise. Core binding factor, which did about 75-80%, ideally with the use of gemtuzumab in the US, with less and less use of allogeneic transplant. And then you had the adverse cytogenetics, which included chromosome 7, 17, deletion 5q, inversion 3p, and complex cytogenetics. And those did really, really poorly with 3 and 5 year survivals of less than 15%. And then everybody else, the 65 to 70%, were all in the middle. This was how it was 20 years ago. Now with the molecular data, you see that middle portion has further been broken down into different subsets. So if you have a patient who does not have clearly APL, does not have clearly core binding factor, and does not clearly have adverse cytogenetics, you really need to have the molecular data. And then based on NPM1, FLT3, RUNX1, and in the most recent ELN and NCCN classifications, even other mutations such as ASXL1, splice mutations, and other secondary-like mutations could independently give you prognostic information that could help you understand the expected survival, and more importantly, help you understand which patients you absolutely must consider stem cell transplant in the first remission. These really include pretty much all patients except for APL, core binding factor, isolated NPM1, NPM1 with a TKD mutation. These are the patients where we would not consider on baseline mutation cytogenetics for transplant. For the remaining, we would be considering transplant in the first remission. Now, we can get into details of MRD and how this can be used maybe to not do transplant in some of those subsets, but I have to say this is still a very early field in its infancy. I do not think today we're making huge decisions on not doing transplant or transplant yet on MRD. Maybe this will come in the future like it has already come for acute lymphoblastic leukemia. Then just to kind of give a highlight of older unfit AML, where we are, I'll get into that more in detail, but I think this is probably the biggest change in general treatment of AML outside of the molecular targeted FLT3, IDH1, IDH2, NPM1 menin. The big change that has come, and the only drug really that has been approved across the board for all AML subsets was venetoclax. This was based on the Viale study led by Dr. Courtney DiNardo in our group. We have enrolled a tremendous number of patients on HMA-ven frontline patients across 4 different studies that have happened in the last 5 years, close to 250 patients. We have a lot of experience and are very, very happy with the results of aza-ven in general compared to what we were getting previously with HMA alone or with other low-intensity therapies alone. Now, that being said, we also are very cognizant that this is just a first step in the progress. And although the median survival was improved, the 3-year survival was improved, the CR/CRI rates were actually dramatically improved, you still see that at the end of the day, this is the most recent update from 6 months ago at ASH with 3-year follow-up plus. Now we're seeing that the 3-year survival is about 25%. So yes, better than 8%, which is what we got to get this 25 to 50, 60, 70%. It's a good first step, but definitely not a home run on its own to cure leukemia for older unfit patients. And I'll talk more about the strategies we're employing in different ways, combination sequences, etc., to try and further enhance this survival. Now, I think the really critical other breakthroughs in addition to venetoclax have come are through targeted therapies. And in red, I show the ones that, at least in the US today, are either approved or being extensively used and established based on clinical data as effective targets, with effective targeted therapies. The ones I know in India that are probably the most used are FLT3 inhibitors. I'm going to spend a lot of time discussing those because I think it makes a lot of practical sense, as those are the ones you have available and can use. The IDH inhibitors, we think they're great drugs. We did a lot of work with them 4 or 5 years ago, myself, Ethan Stein, Courtney DiNardo, others. We got them to approval in the US. We're very happy about that. We continue to use them, and now combination data with those drugs is showing that they continue to show even better outcomes and very, very good tolerability. Unfortunately, in the rest of the world, probably due to the design of the study, which did the usual relapse setting, cytarabine versus drug X, led to a marginal improvement, but did not meet the statistical endpoint. The IDH inhibitors were not approved in relapse, which is very unfortunate. All my colleagues in Europe are quite depressed about that because they would like to use the IDH inhibitors. But luckily now, in the frontline setting through the AGILE study, we have got the approval of the IDH1 inhibitor ivositinib in combination with AZA in Europe and in other regions across Middle East, and hopefully soon in Asia and India. So hopefully we will get in the next year or so some access to IDH inhibitors in India, and then we can discuss more how to use this. I think these are great drugs. And then the next big class that I think will be a major targeted therapy in AML, with expectations potentially even for next year through the US FDA to see some progress, is a group of drugs called the menin inhibitors. There's actually 5 of them already, showing how much excitement there is in the clinical investigators and the pharma for this target. And the ones that are most advanced are Syndax and Kura. But the others, such as J&J Sumitomo, you will see some exciting data at ASH. And these are all different drugs. And we may actually find, like FLT3, that there could be potential for multiple approvals. at MD Anderson, we're involved in actually leading all 5 of these in different ways. And we're very, very excited about the potential of the menin inhibitors. And again, yes, it will take a few years, but we all know MLL rearranged AML, ALL is a very, very difficult and aggressive disease, and having these drugs will help all of us in the next few years. The other groups, which are big unmet needs, a lot of intense research, clinical trials ongoing, but no breakthrough yet that I can state that this is definitive, are the TP53 mutation. There's a lot of activity going on with new targeted drugs, protein folding impacting drugs, immunotherapies, macrophage activation drugs. Hopefully through such intense research, there's more research in TP53 today by far than any part in the past. We will see breakthroughs, but I think it's going to take a few years. But keep an eye on that space, and hopefully we will see some breakthroughs in the future. And then RAS mutations also are becoming a very common pathway of resistance. So whether it's post-FLT3 inhibitors, post-IDH inhibitors, post-venetoclax, the RAS mutation seems to be a common emergent resistant escape pathway. And we are now looking at new class of MEK inhibitors, which seem to be better tolerated, being developed in solid tumors by our phase 1 colleagues. And we're going to now borrow and use them in heme. And I have a good feeling that in the next few years, we are going to get some effective RAS inhibitors that can then avoid or delay resistance to these targeted therapies. So a lot of very interesting things happening there. So this is the landscape in the US. I know in India, some of these are already available, which is great. For example, venetoclax, I know gemtuzumab can be acquired when needed. Midostaurin is available, gilteritinib in certain cases. And then the others hopefully will be coming soon as well, the IDH inhibitors, the maintenance. And then most recently, and I'll talk about this more, very exciting new FLT3 inhibitor. Well, it's not new really, it's been around for 10 years, but new approval of quizartinib, very potent single agent as well as combination FLT3 inhibitor. So let's go into more of the FLT3 discussion, because I think this is something that in India, is very, very relevant. I've discussed this with many of our colleagues on emails and WhatsApp and phone calls. So I think there's no doubt, and I put this slide together just to highlight that FLT3 inhibition is very powerful, very impactful, and very clear. Probably as clear as BCR-ABL inhibition in Philadelphia positive ALL. We now have actually 7 randomized studies that have all shown benefit of FLT3 inhibition in different settings. 2 in the frontline setting with intensive chemo. Here you see the addition of quizartinib in Quantum first on the top, then in the bottom, midostaurin versus placebo ratified. Both showed survival improvement. Use of maintenance, 2 randomized phase 2 studies with sorafenib, both showed maintenance sorafenib versus observation placebo resulted in significantly improved RFS OS post-transplant. And actually a third study, which was the largest post-transplant maintenance study ever done in AML, called the Morpho study of gilteritinib versus placebo, has also shown a survival benefit. And I will show you in which subsets, and this is where MRD does come in a clinical practice, it is best used. We'll talk about that in a little bit. And then in relapse refractory setting as well, there has been a clear benefit. Both second generation FLT3 inhibitors, gilteritinib, quizartinib, did improve response rates, duration of response, ability to get to allotransplant, which you all know is really critical in salvage, as well as survival. Now, that being said, the survival improvement is marginal. And this really is because FLT3 is a highly multi-clonal as well as highly dynamic disease with molecular shifts and clonal evolution, and combinations really are going to be needed. Single agent will get you some initial response, but other clones will quickly relapse and escape. And unless you have a combination, you're not going to get durable or curative outcome. And I'll talk about combination strategies, because I think when we use these drugs, especially in salvage or frontline, especially when we're trying to get the maximum bang for our buck, so to say, or maximum mileage without having to spend huge amounts, it's using them in combinations. You can use these drugs for shorter periods of time, often at lower doses, to get the patient to the next endpoint, which is transplant, rather than using single agent for a long period of time, which is much, much, much more expensive. And I would tell you at MD Anderson, we absolutely 100% are focused on combinations, not just financially, but really more to get a quicker, more effective, deeper response, move to the stem cell transplant, and then try to get a curative outcome. So FLT3 inhibitors, again, for fellows, residents, and others who may be new to the field, there are 2 big classes of FLT3 inhibitors, 2 big flavors. One is a type 1, one is a type 2. The nomenclature is not that important. What one needs to know, though, is what the particular FLT3 inhibitor they're using is targeting. There are 2 types of FLT3 mutations, the ITD, which is about 80% of the mutations, and the TKD, which is about 20% of the mutations. The ITD is the more proliferative, more aggressive, and the one that has historically been associated with adverse outcome. Both types of FLT3 inhibitors, gilteritinib, quizartinib, midostaurin, sorafenib, target ITD. However, there's also a second mutation called the TKD, which is the less common, about 20% of all FLT3 mutations, and only the type 1 inhibitors, specifically gilteritinib, midostaurin, would target the TKD. So one would say, wow, then why should I just not use the type 1 inhibitors? Actually, no, because the type 1 inhibitors, although they work well and cover ITD and TKD, and so you don't see on-target resistance, you don't see on-target emergence of FLT3 TKD as a resistance to gilteritinib, you do see off-target resistance. And we've actually published now that up to 1/3, 35% or so patients may have an emergent mutation in a other pro-survival pathway on gilteritinib, so RAS/MAP kinase, BCR-ABL, and so the escape is outside of the FLT3 domain. And then you could use a drug like quizartinib, for which the resistance is on target, but in fact can still work for patients who may have a low burden RAS/MAP kinase. So just like in CML, where you have drug like imatinib, which works, but then you may get resistance to a non-target mutation, you could switch it to dasatinib, then you could switch it to ponatinib. Similarly here, you could start with quizartinib. If you have on-target resistance with a TKD, you could go to gilteritinib, and then maybe there will be other drugs. We're working on a few other third-generation FLT3 inhibitors, such as ponatinib was in CML, that could then become the next in the sequence. So each of these drugs has independent properties. We just have to know what to expect when you start with one and how we could use the other one in sequence if needed to improve survival. So midostaurin, yes, was the first of those now 11 drugs that have been approved in the US in the last 5 years. But I think, in a way, was kind of a modest survival benefit. It was there. It showed targeted therapy works. Great proof of concept. Yes, people have used midostaurin. I will tell you, MD Anderson, we have always used sorafenib, and I'll show you some of our survival data that even at the same time period as midostaurin was going, to us looked better with sorafenib. Now, the history of sorafenib is a bit political and economical. Bayer was not interested in taking it into leukemia because they had their sights set on the big tumors, liver and renal. And so they said, we'll give it to you to work with at MD Anderson. We were the first group to start using FLT3 inhibitors, Michael Andreev and Gautam Bortakar and others. But they said, we're not going to be supporting any large registration study. Our focus is in solid tumors. So even though sorafenib was a great drug, there was no interest from the sponsor to push for a randomization large study. And so it's been used and it's in the NCCN. However, Novartis did luckily take midostaurin all the way. It led to survival improvement. It has been used. But as we can all see, we would like to get this survival curve delta at a much higher rate. And we think that with the more potent second generation FLT3 inhibitors, gilteritinib, quizartinib, we can do that. Another kind of bit of a history is that midostaurin was not really developed also as a FLT3 inhibitor. It was actually developed for brain tumors, gliomas, and other similar tumors. And then they found, as the field of FLT3 inhibition became more and more important, that it can also target the FLT3 pathway. So that's kind of how it, came into use, but it's not was not developed as a FLT3 inhibitor per se. So now talking about sorafenib, this is the data we have with sorafenib. This was also generated a while ago by Dr. Tapan Kadia in our group. And here we show that the combination of sorafenib with the backbone we use, which is idarubicin cytarabine, so similar to 3+C, but with the addition of cladribine. I know there's been a lot of discussion, etc., but any paper you look at, and there are dozens of them, whenever you look at the backbones using pure analogs, whether it's from the British MRC, from the Polish, or from MD Anderson, Cornell, or from Moffitt, you will always see the survival is a little better. And I think over time, it is becoming more and more clear that the addition of a pure analog does play an important role in enhancing survival in AML. And among all the subsets, probably the subset where it plays the most important role is FLT3. So this was initially something that was preclinically identified by Dr. Bill Plunkett, Varsha Gandhi almost 20 years ago, but then more recently was shown by the Polish group here, where they again showed that it's the FLT3, where what the regimen they call DAC, which is basically daunorubicin, cytarabine with cladribine, similar to what we call CLIA, which is the same 3 drugs, had a specific benefit in FLT3. So if one wanted to consider how to enhance the responses and survival in a FLT3 mutated without using very expensive new drugs that have to be imported, I would very strongly say addition of cladribine is probably one easy step where one can do that with a backbone of the cytarabine anthracycline, and then adding there a drug such as sorafenib. So this is probably one of the least expensive FLT3 induction regimens in the world. And look at the survival we have, 3-year survival, 70%. If you look at the Ratify data, this is actually better. Now, of course, this is something that was done at MD Anderson. We have logistic, a lot of expertise, etc. But I do think the clear sorafenib regimen is a very, very good regimen if one cannot get access to, let's say, gilteritinib or quizartinib. And for anybody who may want to try that, feel free to email me. We will give you the data. We have treated 300-400 people with CLIA, and other large centers, Moffitt, Fred Hutch, Cornell, as well as most of UK and Poland have also been moving to this regimen as the data is becoming stronger and stronger. Now, that being said, even though we're doing well, can we do even better? Sorafenib also was not the best FLT3 inhibitor. Quizartinib, gilteritinib, on the other hand, were developed specifically after the identification of FLT3 as a major molecular marker to be FLT3 inhibitors. And this is the data with the Quantum First study, the so-called. You're going to hear a lot about this. You probably already have, but it will continue with many subsets coming out at ASH and EHA next year. Large global study, close to 450 plus patients were enrolled, randomized 1:1, very similar to design of the midostaurin Ratify study. Here we use 3+7 quizartinib versus 3+7 placebo, and this study took 4 or 5 years to complete. And overall, the primary endpoint was overall survival. A lot of debate for those of you who are Twitter fans. I get more and more frustrated nowadays with Twitter because there's more debate and less information coming out. But there's a lot of debate about why was randomization with placebo. And unfortunately, this is how regulatory processes work, both in US and Europe. At the time when this study was discussed with the US FDA, there was no data out for midostaurin. It was 2017. The Ridgestone data had not been presented yet. And so the standard of care was to use a placebo. And so, you know, launching a large phase 3 global study is a lot of effort, usually a year plus of work, many dozens of millions of dollars, and the study was launched. Then about a year later, the data was presented at ASH showing midostaurin is better. And so the steering committee, of which I was a part of, we all discussed, and the study had already opened in 80 centers, was already enrolling. It was going to be a major amendment, had to change the whole background statistics. And we approached the FDA and they said, well, we will be fine with what was initially agreed to. And so the study continues as it is. It's very difficult to change a large global phase 3 midstream. And unfortunately, that is the way drug development is. I think it also kind of highlights that phase 3 studies may not be the way to go when you have a rapidly changing field with new standards of care emerging every year, every other year. You don't really want to be locked in a 5 or 6 year study. And this is something we're seeing again and again with this study, with the Agile study, and with other studies. So I think this is one of the things where we're pushing heavily for molecular endpoints or MRD-based endpoints as a new standard. And I'll talk about that a little bit more, but this is something that's being very aggressively discussed and pursued both with the FDA and with the clinical investigators in the US. So now that all being said, the survival was met. That is good. You see there was a 11 to 12% survival benefit at 3 years, so bigger delta than what was seen with midostaurin. Also, one has to realize and remember that there were two big differences in this study from Ratify. One was this study allowed patients 18 to 75 years of age. Ratify only allowed 18 to 60 years of age. And in fact, 40%, so close to half the patients on this study were above 60. So they were much older than what would have been ratified. So already you had a more difficult, older population in general. The second thing was that all the patients, 100% here were ITD because quizartinib is a type 2, it hits ITD, whereas in midostaurin, about 30% were TKD. And of course, TKD tends to do better and pulls the curve up. So this was a more difficult, more old population with more ITD enrichment. And in spite of that, we're seeing a better survival curve than what was seen with Ratify. So we all very strongly, pretty much all the FLT3 aficionados and experts in US do really think that quizartinib is a more powerful, better, and more effective drug. And that makes sense because biologically it was designed and it has shown as a single agent much more powerful activity than midostaurin. So we are really switching all our frontline studies. Well, we already were doing the trials with GILT or Quiz, but we will continue to focus on quizartinib, and I think we will see less and less use of midostaurin, both in US and ex-US. Now, subsets are very important because, you know, a lot of people ask me, well, what about a 67-year-old with FLT3 mutated AML, with borderline fitness, you know, a little bit of creatinine issue, a little bit of diabetes? what would you do? Would you give him 3+7 or CLIA, let's say, or intensive induction with quiz, or would you do something else? And so we encourage the company to look at this subset. And as you can see clearly, above 60, this does not look that good. In fact, one can argue, is there much benefit? And again, it's tricky to do this. Statistically, the study was not powered for subset, but really more importantly to me, the part that is not tricky and is clear is the early mortality. So even in a clinical trial where you had to meet eligibility to get on that trial, which we all know is not absolute reflection of real world, and even then done in academic centers, predominantly in Europe and US, you're seeing a 2 to 3 month mortality of close to 20%. So a lot of people argue and say, oh, I can give intensive chemo and my mortality is 1% and 2%. And that's true. Our early mortality with flag-eyed event is very low, but that is in an ultra large center with a lot of checks and balances, with a lot of people monitoring. But outside of that, even in academic centers and in the recent time frame, from 2015 to 2021, when the study was done, the early mortality with induction chemo in a patient above 60 remains very high. So I think this is the most contemporary data set showing that intensive induction should be very selectively used in patients above 60. I'm not saying nobody. There are very healthy, very fit marathon runners, super healthy patients. You could consider it. But in general, we are moving away from intensive chemo, even at MD Anderson and in many, many centers in the US, that is the same thing. So now the new data that I think is very, very important, and probably the first area where MRD is really now critical or has established itself as a clinical evaluation that has direct impact on treatment decision more than a prognostic or just a research tool. So this was a study that was presented by Dr. Mark Levis, very well known for the FLT3 work, a good colleague, friend of mine. And we were very involved. I was closely involved with the development of this study as well. Now, we didn't open it at MD Anderson because we had our own ongoing gilteritinib azacitidine study, which continues to enroll. We'll present some of that data at ASH for post-transplant maintenance. But I'm glad this study was done. So this study took patients who had a FLT3 mutation at diagnosis. So you have a new patient, 50-year-old FLT3 mutation, you give him whatever intensive induction, whatever you want to give him, 3+7 quiz, CLIA, sorafenib, 3+7 Mido, okay, whatever it is. They get into remission, and now you have completed 2 or 3 cycles, you have a donor, whichever donor it was, haplodonor, allo donor, sibling donor, whatever conditioning you're going to use, high-intensity conditioning, low-intensity conditioning, RIC, MAC, fine. And you say this patient is going to go to transplant with such and such a donor and with such and such in conditioning. And the question is that the endpoint? Are you done with transplant, or should we do something beyond transplant as a maintenance to further improve the survival and relapse-free survival of this population? So that was the premise of this study, that transplant alone of whatever entity may not be enough. This is a very proliferative aggressive disease, and post-transplant maintenance, like they do in multiple myeloma, for example, with Revlimid, may further improve the relapse-free survival. The primary endpoint was relapse-free survival, co-primary endpoint or key secondary endpoint, more specifically, was the overall survival. And the patients had to be able to start around 90 days, 3 months or so post-transplant, with a degree of engraftment, basic engraftment, without having significant, so grade 3 or 4 GVHD, which is probably about 50 to 60% of our patients at that time. So again, it's not a reflection of all patients, but probably a bulk of our patients by day 90 would be in somewhere in this situation. And they were randomized for 2 years, gilteritinib versus placebo. So we don't need to go through all these numbers, but basically a total of 356 randomized. This is the largest number that I am aware of that have ever been randomized in a post-transplant maintenance setting, at least in myeloid or even really in lymphoid disease, I would think so. And then half of them got gilteritinib, half of them got placebo. Important here to highlight that the reasons for discontinuation were as we expected and were different. So in those treated with gilteritinib, if you look at the small boxes, the adverse events was the big reason for discontinuation, 17%, as compared to placebo, where it was only 5.6%. On the other hand, when you look at relapse under gilteritinib, you see that only 15 or 8.4% came off your relapse. On placebo, 41 or 23%. So much higher relapse rate, but lower adverse event withdrawal rate. So kind of expected. And how did this impact the overall study? So now you see this is the primary endpoint, where you can see, looking at the curves, to me, it looks good. There is a separation of the curves. The medians are different. However, the p-value is 0.051. One could have in fact, we had a biostatistician who works closely with the FDA come and give us a lecture about how this was completely irrelevant and should not be used for clinical decision making, and that if you see such a survival curve, this implies that there is survival benefit. In fact, it was 2 patients that could have gone either way that could have impacted the outcome. And if you see this curve, and if this is your friend or family member or yourself, I think all of us, at least I would agree that I want to be on the top curve. I'm not going to say, oh, because the statistics is 0.051, hence this is not something I would do. And I think that's at least how we want to practice medicine. MD Anderson is something that you think would be good for yourself or your close ones is what you should offer to patients. If you really think that there's equipoise and that there's no benefit, then fine, that's a different story. But I think we all feel, based on the prior data with sorafenib maintenance randomized studies, prior data of maintenance, there's a whole biological field, and this data confirms that. Of course, there's going to be a lot of discussion already started with the FDA to figure out how to do this. But what I'm very happy they did in this study, and I think this is probably the most important data that comes out of this study, even more than the primary endpoint, is the impact of MRD and post-transplant maintenance. So when Mark showed this data, he showed that they did high sensitivity. Now, this is really the important thing. 10⁻⁻⁶ sensitivity PCR that can be available in certain commercial labs in the US, and hopefully in the future will become available in India. I know the genomic field in India is doing quite well with high sensitivity flow and genomics emerging quickly. So if you can get a high sensitivity MRD assay, and if you have any MRD at any level, meaning 10⁻⁴, 10⁻⁵, 10⁻⁶, that's what they call MRD 4, 5, 6, either immediately pre-transplant or immediately post-transplant. So the bone marrow you do before transplanting and the first bone marrow you do on day 30. If either of those were MRD positive at any level, then what about those patients? Because intuitively, biologically, you will think that that is the patient where maintenance should work the best. You can see, yes, it's small, but you can see some small 1 in million or 1 in 10 million even FLT3 clone present. And that was about 50% of the population. So about 46% were pre-transplant, an additional 5% they found on day 30 post-transplant were MRD positive FLT3. And so they said, what about this population? And now you see the big difference. So for that 51%, more than a little bit more than half of the study, use of the gilteritinib post-transplant clearly improves survival. And so first, actually, this curve is showing something else. So this is showing all MRD. So let's take all 356 patients, forget about what they got, gilt or placebo. If they were MRD negative versus MRD positive, peri-transplant, yes, MRD negative did better than MRD positive, which makes sense. We all know that. It's quite interesting here, actually, and we've discussed this a lot, that the MRD positive are doing so well. Because if you look at every prior data set that's been published from the Fred Hutch, from our group, from Peter Valk and the European group, from the UK group, all of them have shown MRD positive is way down there, close to 30, 40%. So it's impressive here. This may be that we're just getting better at treating FLT3 as well as treating relapse FLT3, that the MRD positive actually were close to 60% survival at 3 years. MRD negative is what was expected. So that's fine. MRD negative is still better. That's good to know, but MRD positive could also be salvaged. That's a positive thing that we have not seen in prior publications where MRD positive were doing so poorly. But more importantly is this question. So if you're MRD positive and then you got gilteritinib versus placebo, now you start seeing the real biological effect of the FLT3 inhibitor, where patients who got the gilteritinib have a better survival clearly than those who did not get the gilteritinib. In fact, if you look at these two curves, what you can see, again, statistically, one can keep arguing about it, but if you look at the blue line, which is the patients who got the gilteritinib on the curve with MRD positive, this is basically very similar to the two curves with MRD negative. So what Mark said, and what I agree, is basically use of gilteritinib in an MRD positive situation can pull your curve up to a level of what you would achieve with MRD negative. Now, none of us can predict or control who will be MRD negative, not today at least, maybe in the future if we have MRD razor drug like blinatumomab. So the best thing we can do is, if somebody's MRD positive, for sure give them gilteritinib, and you could equate their outcomes to those who are MRD negative. And that's quite a big thing, getting a MRD improvement in patients. That's something we've never really seen in the AML field. We've seen it in ALL, of course, with blinatumomab. And so I think this really supports the use of molecular directed use of maintenance. But of course, To do that, you have to have the molecular test. And that is the big problem. Even we at Anderson have not routinely been using 10 raised to minus 6. We have an assay of 10 raised to minus 3 more for diagnostic and use a FLT3 inhibitor up front. But we are very rapidly working with one of the commercial labs in the US that has developed this assay to get this for our patients, because we now realize that it's critical for us to make this decision in FLT3 mutated patients going to transplant. Now, till then, what will we do? Every week we're transplanting FLT3 mutated patients. What will I do? I will give them gilteritinib, because at the end of the day, I want my patient to be on that top curve, whether it's in the MRD positive or MRD negative. And if I cannot say with full confidence that my patient is MRD negative without having a sensitive assay, then I'm going to err on the side of giving them gilteritinib and getting their survival curve higher. Of course, there's a cost impact. The good thing with gilteritinib is the toxicity impact is limited. It's not a huge toxicity. One does have to be aware of neutropenia, manage it, dose adjusted, interaction with azoles, but among the many drugs in AML is probably one of the best tolerated. And so I think the benefit risk ratio here is towards giving gilteritinib. And to all the people who email me, it's amazing how many emails we've gotten after this study, just within the US, from dozens of doctors and community, etc. And today our stance is try to get MRD assay very quickly. Once you have that and you can get to 10 raised to minus 6, then use that assay to decide who you're going to give gilteritinib post-transplant. If you don't have it today, which is 90% of the centers in the US, then give gilteritinib post-transplant maintenance. Do it carefully. Start at 80 milligrams. That is one strong recommendation we have. All our studies were with 80. And I think we are seeing better tolerance than what they saw at 120, and monitor closely for liver enzymes, neutropenia. And if needed, don't be worried to interrupt it, but try to give the maintenance. The second question we give is how long? This study did it for 2 years. I think that's reasonable. I've had some really young patients, especially in the relapse setting, who've completed 2 years. They're 30, 40 years old. They're nervous. Their insurance is covering it. They're on 80 gil without toxicities for the last 1.5, 2 years. They want to continue. I do not push them to absolutely stop. We do not know 5 and 10-year data. And as you know, in ALL, we did see that patients who came off TKI post-transplant, there were delayed relapses, as published by Dr. Jabur Kantarjan from our group. So I think 2 years is reasonable, especially if there's financial or patient resistance to continue. But if a patient is anxious and says, is there any chance I could relapse late, doctor? I say, yeah, there is some chance. And they say, I'm happy, I'm continuing it. Insurance is giving to me. I'm back to college. I'm back to work. It's not impacting me like a blood pressure medicine. I'm going to keep taking it. I say, that's fine too. We'll keep following you every 6 months, and we will see what the long-term impact is. But 2 years, I think, is a good number to start with. So here just showing, and this is also very interesting, a little bit different from what was seen previously, is that myeloablative conditioning was not directly associated with the clear, the other way around. Myeloablative conditioning actually was associated with better survival in patients, whether they were MRD negative or positive. So if you recall the data from Chris Horrigan, where he showed that those who were MRD negative, myeloablative conditioning had a benefit, did not have a benefit, but those who were MRD positive, myeloablative conditioning had a benefit. In this study, they actually saw that whether you were MRD negative or MRD positive, myeloablative conditioning had a benefit in those patient outcomes. So again, kind of a little bit different here than what Chris Horrigan showed. In our group, I will say at MD Anderson, our transplanters, Dr. Shpal and Popat and others, we do lean towards myeloablative conditioning more and more, especially in people who are MRD positive. But I think now even those who are MRD negative, if we think they can tolerate it, we are pushing. So the other thing I think is to consider more and more myeloablative conditioning approaches for your patient population, if that is available. Of course, there's always selection bias, and there are some patients who cannot get it, sure. But I know there were some centers in the US that were just using RIC across the board. And I think a lot of the molecular and MRD data suggesting that that is a very risky proposition. And we are all going back towards more and more pushing towards myeloablative as our standard, with RIC as a backup for somebody who's really frail or you're really worried about post-transplant mortality. Now, the other thing that comes up is why do we think that maintenance didn't work as well as we thought it was? We did not think we were going to have this whole debate of 0.051 and yes, this and that. We thought it was going to be clean, home run, amazing, great. And I think the reason is a few things. So one is FLT3 is a mutation that is dynamic. It goes away in many, many patients. In fact, as we're seeing more and more, we're seeing close to 50% of patients could lose the FLT3 mutation at relapse. This is now from 3 different studies. So if you don't have a high sensitivity molecular assay, it's quite possible for those people who are molecular negative at 10 raised to minus 6, the FLT3 is gone. You did a great job of actually eradicating the FLT3 with your intensive chemo FLT3. And now you're giving a drug, gilteritinib, which predominantly is a FLT3 inhibitor, has very little wild type activity, and you're not getting any benefit. And probably you're still getting some neutropenia and transaminitis and discontinuation. And so the benefit may have been lost. So I think this is the key, that by using a molecular test, you're actually picking those 50%, 55% who have some FLT3 and you're targeting it. For the others, you may want to use other maintenance. There are other studies looking at oral HMA, HMA-VEN, or you may not need maintenance at all. So this kind of, I think, explains to some extent why the maintenance across the board may not have worked for some of those patients. So where are we with FLT3? And I think this is, again, probably important for many of you as to what can you do today in India to try to improve outcomes, at least in, let's say, FLT3 AML. So I would say, in our opinion, cladribine use as a backbone in addition to cytarabine anthracycline has shown now in multiple studies benefit, but specifically in FLT3 has shown the most benefit. So that is our induction regimen: cladribine anthracycline, cytarabine. Use of a FLT3 inhibitor, sorafenib with cladribine, cytarabine, anthracycline is quite good, the survival data. But of course, if you can get access in the future to quizartinib, then one could do quizartinib added to that backbone, and those studies are ongoing. Allogenic transplant is critical in first remission, and this could also save a lot of time, money, hospitalization, infection. So you want to really set up transplant from day one for these FLT3 mutated. You know they're FLT3 mutated. We get our transplanters involved. We give them CLIA with gilteritinib or quizartinib, whatever is open on the clinical trial. 2 cycles ideally, maximum 3, but 2 cycles ideally. We want to move towards allotransplant, whether it's with sibling donor, haplodonor, allodonor, and then post-transplant, we would start on maintenance. That as well, maybe we can use molecular high sensitivity MRD to decide who needs maintenance and who doesn't. But I think with all these steps, you can really shorten the duration of your treatment, move patients quickly to a curative outcome, and hopefully reduce the overall cost of care. So I think today in India, clear sorafenib sort of approach, followed by transplant quickly 2 to 3 cycles, and then maintenance. And now remember, even for maintenance, you could use sorafenib. There is clear data with sorafenib for maintenance if gilteritinib is not available. Sorafenib is harder to tolerate as maintenance post-transplant, so we don't really like it as much because of the GVHD toxicities. But if that is the only option, then we have to do that and adjust the doses. We often start with a low dose and then move up to a higher dose. So I think these are the strategies one could consider in India to improve outcome without really having to shoot up the cost of care. And maybe in the future, as GILT and others become available, those could be used as well. So this is our current approach today, where we use the pure analog with cytarabine anthracycline-based treatment, add a FLT3 inhibitor, try to go into remission with 2, ideally maybe 3 maximum cycles, and move to transplant right away, 2 to 3 cycles again. Patients going to transplant, we are considering using maintenance today for all patients, but as we get high sensitivity molecular assays for those who have a residual molecular FLT3, and the maintenance today is planned for about 2 years, but it could be increased or decreased as needed. So now I'll go a little bit about the relapse. So relapse FLT3, gilteritinib single agent has shown activity, but again, when you talk about either efficacy, curative outcome, or the economic benefit, I think it's a little bit hard to argue 9 versus 5.5 months is good, but it's not great for a drug that can cost a lot of money. So what can we do? So we started understanding various mechanisms of resistance to different FLT3 inhibitors. And we know that unlike BCR-ABL or PML-RAR, the resistance for FLT3 does not all happen in the same pathway. You can see multimodal resistance. It's not only acquisition of mutation in the ABL kinase domain, like you see with CML or folate positive ALL. You can see other mutations, RAS, MAP kinase, BCR-ABL. You can see tumor microenvironmental factors. You can see changes in pro-apoptotic and anti-apoptotic balance. And so again, just getting a better FLT3 inhibitor, even if we had the best FLT3 inhibitor in the world 5 years from now, I do not think it will lead to a cure like ponatinib could do in CML. I think you will still see a lot of off-target non-FLT3 escape, maybe up to 40-50%. So now we need to look at other strategies beyond just getting better and better, just targeting the FLT3 clone. Of course, the other strategies as well, can we then combine it? We know a lot of these clones that we're talking about could be sensitive to other drugs in AML, venetoclax, hypomethylating agents, intensive chemotherapy, low-dose cytarabine. And of course, the one that kind of makes the most sense is an oral drug, is well tolerated, can be delivered in combinations in many, many settings, is venetoclax. And interestingly, we also found this was work done by Marina Konopleva and then was replicated by many other labs. Tony Latai and others showed that the venetoclax resistance was heavily mediated by upregulation of MCL1 and BCL-XL. And interestingly, many of the FLT3 inhibitors, including gilteritinib, quizartinib, suppress MCL1 and BCL2. And so not only is there a 1+1 effect targeting venetoclax, BCL2, targeting FLT3 inhibitor, but you're also getting a suppression of venetoclax resistance by a secondary effect of the FLT3 inhibitor suppressing MCL1. So that's quite cool. And that shows that there was synergy really beyond just the additive effects of these drugs. This then led to clinical trials where we combined venetoclax with gilteritinib, and you have probably seen or heard of many such combinations, and they will continue to grow of venetoclax with other drugs. And we see that the combination gave us very encouraging response rates, close to 80% CRC rates. However, when you look at true CR rate, that is about 30 to 35%. But you have to realize these are salvage 2 and salvage 3 patients. This is not frontline. And 10 years ago, to get any response in a salvage 2 and salvage 3 FLT3 was difficult. Response rates were less than 20%. With gilteritinib, this moved up to about 40, 45%. And now with the combo, we're at 80%. And really, the best use of this regimen is in patients where we're trying to move them to allotransplant. So you have a patient, 50, 55, got intensive chemo FLT3, for some reason or other, either went to transplant, didn't go to transplant, relapses 8 months later, and then you give them this regimen. And if they have not had a transplant, they can move to transplant. If they've had a transplant, we've actually done second transplants because we've seen really deep responses with this. But it is difficult to continue this regimen for 12, 14, 18 months. It can be done, but you really have to drop the venetoclax. But for younger patients where we want to get a clearance of the marrow, achieve a deep remission, not worried about count recovery because we're going to move to transplant quickly in the next 1 or 2 months, this is a very effective regimen. And just showing here that if you do move to transplant, which should be the goal with this regimen, after 2 or 3 cycles, after achieving marrow remission at least, you can see, even in a salvage 2 or 3 population, a durable survival. We've never seen a survival curve at 50 to 60% at 1 year and beyond in a relapse refractory salvage 2 and 3 population in AML. So this is quite encouraging. This is being used in the US extensively. And again, if one asks me, should I just use gilteritinib single agent? I probably would say, again, economically, if you're going to try to get this patient a transplant, use the combination, do 2-3 cycles, get your transplant ready, move to transplant. That's cheaper than giving gilteritinib for 12, 18 months. And you're also going to get almost double the response rates and a better curative outcome. So less expensive and a better outcome. I think that is hard to argue at this point in time. The same holds true in the frontline setting. You know, people are saying, okay, let's use HMA-VEN for our FLT3 mutated patients. And you can do that. And HMA-VEN has a response rate, 67, 70%, but the responses are not durable. Only about 11-month survival in the final publication. In fact, some are saying it's not that much better than AZA, 8 months versus 11. It's still a little bit better, but not much better. So I think, again, here, the question is, what can we do to improve the outcome? Was very nicely shown in the ASH meeting that when we looked at the molecular baseline of all the patients treated with AZA-VEN, and we did a scoring system to identify a prognostic scoring system, because remember, ELN historically has been based on intensive chemo. So the ELN group with Dr. Donor and others wanted to identify a new lower intensity ELN model. They found that the mutations that really were important were TP53 mutation. These people do extremely poorly. And then FLT3 and RAS. So if you had either of those, FLT3 or RAS, you had about a 12-month median survival, less than the rest. And for the others, so those who did not have TP53, did not have RAS, did not have FLT3, actually HMA-VEN does quite well. Median survival of 26 to 27 months. Remember, these are 70+ patients. A median survival of 2.5 years is really quite good. But we need to do better for the TP53 and for the FLT3 and RAS. So then we start talking about triplets. And this is, I think, the next thing you're going to hear for the next 5 to 10 years. And in our mind, there's no doubt that they're going to come, whether it is in a optimal modified way or whether people don't do it appropriately. I think that is the big question. And just like any other triplets, they can be very, very loving and they can give you a lot of joy, but they can also make you pull your hair out if you don't manage things properly. So we at MD Anderson have been heavily moving into the triplet direction. A lot of this is, of course, borrowed knowledge from what we did in ALL, where we're incorporating the antibodies with chemo, multiple myeloma, where we combine our best agents up front, lymphoma, again, where we combine our best agents up front. So I think we know over the last 30 years that if you really want to improve not just medians, but actual cure rates, you have to use your best treatments up front, eradicate all of the resistant or escape clones, and then you can have curative outcome. And that's what we're starting to see here with the aza-ven FLT3 inhibitor. This was retrospective analysis that Dr. Yilmaz from our group put together and we published, showing that with the third drug, FLT3 inhibitor added to HMA-ven, the response rates were doubled. True CR rate of 67 versus 32%. Remember, in VIALE-A, the CR rate was about 35% for FLT3. So this is a very good CR rate, as well as a early signal for improved survival. And most importantly, 60-day mortality was the same. Actually, it was a little bit lower with the triplet, probably because of a deeper response and better count recovery. So we then said, as you work on these, you have to realize that the triplets have to be optimized. I think that is the most critical thing. You cannot give 7 days of AZA, 28 days of VEN, and GILT 120 continuous. That will cause major myelosuppression and patients will never recover their counts. We had to work a lot with the US FDA because they are always hesitant about reducing the labeled dose of a drug. And we had to show in small cohorts of 3 to 5 patients that if you tried to give full labeled doses of VEN and GILT, it was toxic. And over 3 amendments, we now have come to what I think is the very, very, very good regimen of venetoclax 14 days only, gilteritinib 14 days only at 80 milligrams, in fact. And we do a bone marrow on day 14. And we're seeing that close to 100% of the patients already by day 14 have achieved either a marrow remission or a marrow clearance, aplasia, ablation, and that giving them 21 or 28 days of VEN or 21 or 28 days of GILT would just add myelotoxicity. It sounds obvious, but when you're working in a regulatory environment and trying to adjust a treatment schedule that's going to be used broadly across other centers and countries, takes a lot of work to amend these studies and get it by the FDA, and then you have to restart. But finally, the FDA and we agree that this is a regimen that seems to be optimal, even though it's lower than the label in the triplet combination, is a good dosing approach. And that is now showing in the clinical setting where with the combination, we are seeing very, very good response rates. The overall response rate is 100%. That's hard to argue. We actually now have enrolled all 30 patients on this smaller investigator-initiated study, and it remains 100%. More importantly, because people always worry, oh, the count recovery. The count recovery is great, 90%. The true CR rate in FLT3 with aza-ven was 35%. Here it is 90%. So we are getting count recovery, but again, with that attenuated 14 days of VEN, 14 days of GILT, not more than that required. And now we're starting to see some survival, only 12-month follow-up. So we'll have an update on this at ASH later this year, but it does look very, very encouraging with a 1-year survival of 85%. With aza-ven, the 1-year survival in this group was about 35 to 40%. So almost being doubled and taken forward. As I said, count recovery is very, very good if you use the right dosing regimen, 14 days of each. In fact, the count recovery for ANC was 37 days, platelets was 25 days. With aza-ven, the ANC recovery is 34 days, platelet recovery was 28 days. So we're actually getting almost the same count recovery as the aza-ven doublet as we have optimized the triplet. And this has now led to a large registration sort of study ongoing in the US at 40 centers to confirm our dosing regimen and to see if this can be done in multiple centers. And I think very possible this could lead eventually to an NCCN or label as being the standard of care for frontline. And again, here, I think, one would argue, well, the cost of the drugs are so much. But in fact, the way we have done the study is it's a de-escalation approach. So you get aza-ven, GILT for up to the first 3 to 6 cycles is what we're planning. Then we drop aza-GILT for another 3 to 6, and then we're going to GILT alone. So instead of continuing aza-ven for a long period of time, and then the cost of patients relapsing and coming to the hospital and going to the ICU, giving them intensive chemotherapy, trying to transplant them, we're going to start with 3 drugs. After 3 to 4 cycles, go to 2 drugs, and then go to 1 drug. And we haven't decided, but eventually, if we see good durability, we may even stop treatment around 18 months. So this will become a shorter time-limited therapy rather than a continuous long-term treatment and then having to deal with more relapses, etc. down the line. So I think in the interest of time, I'm gonna stop here. We've kind of focused a lot on FLT3, but I think that's good because you have a lot of FLT3 mutated patients. The next question that's coming, and I think this will be a very interesting question that could really revolutionize the field, is whether you need intensive chemo even in younger, fitter patients. So this is something for the last 2 years now. The question is starting to come up. I don't think we're there yet. I think we need more mature data. But when you look at these survival curves, the clear-sorafenib, the clear-gilteritinib from our group, or the quantum first 3+7 quizartinib, and the aza-ven gilteritinib, you can start seeing that it's quite possible that the low intensity with gilt will do as well or maybe even better. And this would be kind of like the myeloma paradigm where, you know, Revlimid with Dex, with the addition of bortezomib, was clearly superior to adriamycin, vincristine, dexamethasone, and replaced intensive chemo in multiple myeloma forever. So we're hoping that this may be happening in the future with the low intensity therapy fit the FLT3. So let me stop there, and you know, we'll give some time for question answer, and we can always have a second portion of the talk in the future.
Thank you, Dr. Naval Davar, for that great talk. You're always wonderful to hear, as always. Thank you so much for joining us this evening for us and morning for you. So we have our Indian colleagues who will bother you with all the question answer session now. So to start with, we have with us Dr. Rajan Yadav. Dr. Rajan Yadav, your question, please.
Good morning, sir. Thanks very much for the lucid talk. I have a very basic question. In a poor risk AML, is 3+7 still a strategy to go to, or is there something else that you're looking for?
Poor risk defined by
NGS.
NGS, so like TP53 is kind of what we're thinking about. Yeah. So no, the answer is no. Yeah, we're not using intensive chemo of any type, 3+7 or CLIA or FLAG-IDA in our TP53 mutated. We're actually doing HMA-based therapy. Now, when we say TP53, of course, one has what we call the real TP53, meaning high allelic burden, ideally above 20-30%, or adverse cytogenetics associated with it, or multiple biallelic, right? Because there are a small group, about 15%, 15% TP53, they could have a really low allelic burden and diploid cytogenetics. We actually published that those patients can do well with intensive chemo. So I think it's important when you see TP53, if you can get the allelic burden and the associated cytogenetics, and then if it's a real TP53 driven, then I would do HMA. The question really is coming, for us, HMA basis is clear. The question we have is whether one should use HMA-ven or HMA alone. And in our group, even with a lot of AML experts, there are some that believe that venetoclax is not improving outcomes and is actually causing more myelosuppression and maybe also increasing the expansion of TP53. And so they're preferring to use decitabine 10 days alone or HMA alone. There are others who believe that if I want to get the patient transplant, yes, even though the long-term survival is not better with HMA-ven compared to HMA, you can get an earlier CR/CRi, which has been shown, and then I can move the patient transplant. We don't know the answer to that, but I would say across the large academic centers in the US, we are not using intensive chemo for a true TP53 driven disease. It's either HMA or HMA-ven.
Thank you so much, sir.
Thank you, Dr. Rajan Yadav. Dr. Rama, your question, please.
Yes, sir. Thank you so much for that wonderful talk. I have also a basic question. What is the initial genetic panel we need to monitor for MRD of AML, and is it same for all? Even with AML with genetic abnormalities, we need to have this genetic panel to monitor, and which is important so that therapeutic benefit is there for this MRD monitoring. Which panel you could suggest?
Yeah, that's a great question, and you know, I overshot on the FLT3 portion, so we didn't have much time about MRD. But so I would say today in clinical practice, just to give a simple answer on MRD, what we do is flow MRD. That's still our backbone, bread and butter, most common thing, both at Anderson and most big centers in the US. The flow MRD per the FDA and per the ELN should have a sensitivity of at least 10⁻⁻3, so less than 0.1, to be considered to be a valid. And the way we use it is, let's say you have a newly diagnosed frontline AML and they have intermediate features, so they don't have any of the defining mutations or cytogenetics that would consider them favorable or unfavorable. We would give them induction, 2 to 3 consolidation. If they're truly flow MRD negative, then there's a discussion on whether we should consider moving to transplant for an intermediate ELN or doing maintenance. And we have many maintenance studies of HMA plus VEN, HMA plus FLT3, oral HMA plus FLT3, so on and so forth. I would say today we're still relying heavily on the baseline features, and an intermediate risk ELN below 65. I am still moving towards transplant if they get MRD negative, although this is one area one can debate. I think the two other areas where MRD is most clear are in the molecular setting. So core binding factor in version 16.821, the PCR for MRD is very, very, very prognostic. And if we do not see achievement of less than 0.1%, so at least a 3-log reduction in MRD by third cycle, then we are worried that this patient may be one of the rare resistant core binding factor. We may intensify therapy by adding additional doses of IDA or gemtuzumab for subsequent cycles, and we may consider transplant if there's still MRD molecular greater than 0.1 by the end of the 5th cycle of consolidation for core binding factor. So in core binding factor, if you don't achieve MRD less than 10⁻³ after 4 or 5 consolidation, we consider transplant. The second and the third group is FLT3, and I think that's probably the one that I mentioned is probably the most powerful clinical data set from Morpho, that in patients with FLT3 mutated going to transplant, if they have a FLT3 MRD positive on a high sensitivity molecular assay at any level, 10⁻⁵, 6, 4, then use of a FLT3 inhibitor post-transplant was critical. And then last one is NPM1. I think this one is still, it's tricky because you really have to have a high sensitivity NPM1. But if you have a high sensitivity NPM1 and you can achieve NPM1 PCR below 10⁻⁴, then one could consider for those patients not doing transplant and monitor the NPM1 transcript consecutively over time. So I think these are the 4 big valid areas: FLT3 in the transplant setting for use of maintenance or not, NPM1 to decide whether a patient may not need transplant if they're achieving a true less than 10⁻⁴, -5 NPM1 clearance, and then most importantly, monitoring the NPM1. If the NPM1 is coming up 1 log, it's almost certainly or very high incidence that this is a predictor of relapse. And then core binding factor, if you're not achieving less than 0.1 deep core binding factor after 4 or 5 cycles of intensive chemo, considering transplant in that core binding factor high risk group, rare, but few of them may be there. And flow MRD, we're still using it, but I think today we still make the main transplant decision upfront early on based on underlying molecular futures. So that's kind of where the MRD field is today, but this will continue to change rapidly.
Thank you so much, sir, for that great explanation.
Thank you, Dr. Rama. Dr. Abdul Shahid, your question, please.
Good evening, sir. Thank you so much for all those wonderful information. I'm going to ask a very basic clinical question scenario that a patient who is 68-year-old. I have a patient who is 68-year-old lady with multiple comorbidities. She was diagnosed as AML, and she could not afford venetoclax, so I put her on decitabine. For past 2 years, she is on decitabine. She appears to be in remission. So what is the role of MRD in this patient, and how long I should continue her decitabine?
So sorry, I missed it. She got, what was her initial therapy?
She received decitabine only, a low-dose therapy decitabine. She didn't receive venetoclax. She could not afford venetoclax. So that time it was pretty costly in India. So gave her decitabine. She did pretty good. I think I'd say she has completed 24 cycles of decitabine. So I'm still confused whether to continue or to stop it. But is there any role of MRD in this particular patient?
Yeah, so this answer is yeah. I actually have a slide. I can send my deck to you all. You can look at it. But we published Ravandi and Bodu, one of our fellows here now is a faculty in Cleveland. that even in HMA-based therapy, that MRD still holds value. But even those who are MRD negative, it's never 100%. It was about 70% long-term cure rate. But you have to remember that that was all in the setting of people continuing to get the HMA, because we never historically or even today have stopped the HMA. So if you're getting an HMA and you achieve MRD negative and you're continuing the HMA, it's a good prognostic marker. Those patients tend to live longer than those who are getting HMA and are MRD positive and continue HMA. Your question is, can we stop the HMA? We don't know that. For that, there's really little data on stopping HMA or HMA bends. So if the patient can afford it, and if it's something that's not causing a huge quality of life issue, which it usually isn't, HMA alone, I would try to continue it. I could spread out the cycles. So sometimes we go to every 6 weeks, 8 weeks, give more time. But I'm always hesitant. I've seen people relapse 2, 3, 4 years later after stopping. So yeah.
Thank you. Thank you so much.
Thank you, Dr. Abdul Shahid. Dr. Nidhi Jain, your question, please.
Thank you, sir, for that excellent talk. The question which I have, you mentioned that in a patient who's got AML with FLT3 mutation, you would do the intensive induction followed by 1 or 2 cycles of consolidation, and then consider the patient for transplant. So my question is, if the patient achieves a CR as well as a MRD negativity after only the induction itself, still would you proceed with those 2 more cycles of consolidation, or you can take the patient up directly for transplant after one like the intensive induction? Because that would in our scenario save a lot of cost for the patient. Giving 2 more cycles of consolidation would add up to the cost. So what is your comment on that?
And for which, any molecular group or a specific molecular?
So mainly FLT3 I'm asking, and
FLT3.
even for the other molecular group where you would consider transplant in CR1.
Yeah, I mean, so for us, it's as soon as you can go to transplant, as long as they're in remission. So yeah, for a FLT3 patient, if you give them intensive chemo FLT3 inhibitor, they go into remission and you have a donor ready to go, then you could go to transplant directly. I think the question there would be, again, whether we can do maintenance or not. I probably would do maintenance if you can get it. But yeah, there's no reason one has to wait 2 to 3 cycles. So yeah, as soon as you can, go ahead.
Right. Thank you, sir. And my another question in continuation with the last discussion regarding using FLT3 inhibitors as the post-transplant maintenance. Suppose a patient achieves a FLT3 negativity pre-transplant. So would you not consider this patient for a maintenance with FLT3 inhibitor, or, considering, I don't know.
Yes, but with the heavy caveat that has to be a very sensitive assay.
Correct.
Because today we have, even at Anderson, our in-house assay is 10⁻⁻3. So negative may not be negative, because we know that 30-40% of those that are being read negative on 10⁻⁻3 will have a 10⁻⁻4, 5, or 6 clone. So once we get, hopefully in the next couple of months, we and many centers in the US will get it. And hopefully in India, there's a way to get such a high sensitivity assay. It could be developed by many labs. I'm sure it's a technology. Then yes, if you're truly 10⁻⁻6 negative, I think that would be a patient that I would consider not doing maintenance based on the data there. But you have to have that really sensitive assay. Until we get that, we're going to err on side of doing the maintenance. But we do start with a lower dose. Gilteritinib, we do 80, and sorafenib, we usually start with 200 BID or even 200 once a day, and then slowly ramp it up to make sure patients don't have a full discontinuation.
And so when do you add the maintenance, like post-transplant on days plus 60 or?
Usually between 45 to 90, but even if it's a little later, I mean, some patients have GVHD, so it's more important to give the transplant than the timing. But ideally, if a patient's doing well, around day 60 to 90, but I've had some where I have to start day 110, 120, they had GVHD, we managed it, then we started later.
Okay, thank you so much, sir. Yeah.
Sure.
Thank you, Dr. Nidhi Jain. Dr. Sandeep Nimani, your question, please.
Yeah, good morning, sir. Very nice talk. So I have a simple practical question. FLT3 report is usually not available with us on day 1. So it takes around a week's time. So like the modifications you told to add FLT3 inhibitors or cladribine. So any modifications you will suggest, because that is not there with us on the day 1.
Yeah, that's tricky, because you're right. If you don't have it, it's hard, because the cladribine is given early on. So I think the modifications would be adding the FLT3 inhibitor for sure whenever you get the result. The second is, early transplant, as we discussed in the previous question, trying to move them to transplant ideally after the second, if you can, even after the first cycle. and then using a FLT3 maintenance early to prevent relapse. In the end of the day, I mean, at least in the US, the cost of a relapse AML is very, very high. If somebody relapses, they get admitted, they're in the ICU, they're sick, that usually ends up as hundreds of thousands of dollars. It's much cheaper for us to prevent relapse, even with an expensive oral therapy, than get a relapse. So I think when people focus on cost of care, they focus heavily on the drug cost, but the cost of relapse management is a huge amount as well. So I think, yeah, adding FLT3 inhibitor, transplant, maintenance are the things you could do.
And one more thing, less intensive treatment for AML, going into MRD and transplant is equal for you with intensive chemotherapy, MRD negative and transplant. You got like less intensive treatment, achieving MRD, and you're doing a allo transplant in CR1 versus intensive chemotherapies, MRD negative and CR1 transplant. Both are equal for you?
Yeah, so we actually have a paper published on that recently. Nick Short is the last author. You can look it up, where we looked at exactly the question you're saying. 3 different intensive regimens: traditional intensive, CLIA, FLAG-IDA, CLIA-VEN, cladribine, low-dose RC-VEN, which is like a moderate-ish intensity, and then HMA-VEN. And what we showed is that once you achieve MRD negative and go to transplant, the outcome post-transplant was the same. So there was nothing unique, because a lot of people ask the same thing, that is there something unique that we don't understand about intensive chemo, that it gives a deeper effect that has a better outcome post-transplant? And the answer was no. If you achieve MRD negative, you achieve MRD negative. That trumps everything else. Yeah.
And last thing, venetoclax using for a lesser duration. Any thoughts? Like not using for 28 days hold, venetoclax, using for lesser duration.
Yeah. No, absolutely. No, I would strongly recommend never using it for 28 days, actually. So we use venetoclax usually if we're doing just HMA-VEN 21 days. If we're adding a third drug, whether it's a FLT3 or IDH or other agents, then we're doing 14 days. But there's also, I think, a question about whether 14 days of VEN just would be enough in HMA-VEN. There's actually going to be a cooperative group study in the US looking at HMA-VEN 14 versus 28. And the French also showed a data with Stéphane Breton with 7 days of VEN. Now that data is a little tricky. The infection rates were the same, etc. I'm not sure. 7, I would be a little nervous, but I think 21 or 14 even, depending on your fitness, if you have a frail patient, infection, comorbidity, you're worried you want to do 14, I think it's very, very reasonable to start with that approach. Yeah.
Thank you. Thank you.
Well, Dr. Khurana, I'm gonna have to run. Sorry, I've got some stuff going on in the house, but I'm happy to take more questions on email later down the line if people would like.
Fine, no problem, sir. So I can email you all the questions, because there are so many questions lying from the audience also.
I know, I would love to. Yeah,
I will email you all the questions, because there are 5-10 questions from the audience. So fine, sir. I will email.
Yeah. Sure.
Thank you so much for joining us.
We have a birthday party for we have a birthday party for my son, and so my wife is getting nervous, so I have to go.
Wish him a very, very happy
Oh,
birthday.
happy birthday, sir.
Thank you. Thank you.
Thank you, sir. Thank you so much. That was great.
Thank you all.
Thank you. Thank you for a wonderful lecture, wonderful discussion. Thank you so much. So I now hand over to Zydus for the final vote of thanks.
Thank you, Dr. Naval Davar, for sparing your valuable time. It was a lucid presentation, and you have covered the topic in totality, and we have many key takeaways from this wonderful presentation. On behalf of Zydus, I thank Mumbai Hematology Group, Dr. M.B. Agarwal, for providing us this wonderful opportunity and making us a part of this esteemed academic discussion. I also thank all the discussants and participants who have joined us for this webinar. Special thanks to Dr. Amit Khurana for navigating the entire program in a highly proficient manner. Last but not the least, this series of webinar is possible only because of continuous support from Perfect Square team. Thank you to them as well. Thank you so much, everybody, and have a wonderful weekend.
Thank you.